It's preparing to go live. What can I do from here? Are we going live, Carly?
I haven't seen the live button here yet.
I haven't seen it yet either.
It will tell you now live. This meeting, got it. We're live.
We live?
We are live.
I haven't seen it yet.
We are live on YouTube.
Okay. Good afternoon, everyone, and thanks for joining our educational health Jaminar on this Sunday afternoon, when I know you could have been otherwise occupied. My name is Beverly Frey, and I'm the chair of the Jamaica Diaspora Health Task Force. This afternoon's Jaminar is being presented by Marsha Mullings. Marsha Mullings is an epidemiologist who is fascinated by the scope and complexity of human diseases. She spends a lot of time thinking about diseases, tracking them, and analyzing the data connected to those conditions. Her goal is to understand and to provide the information that helps us to get ahead of those conditions. Marsha has a wide-ranging professional footprint that includes working in academic research, working in partnership with state and federal agencies such as the CDC, working for the State Department of Health, and working in research and development in Australia. The common thread among these varied disciplines and regions is building successful collaborative partnerships to create meaningful impact on target communities. Marsha's work has given her extensive experience in epidemiological research and data analysis, directing surveillance programs and activities, collaborating with local and national health surveillance bodies, spearheading multiple healthcare equity projects, conducting research and development activities, and writing and disseminating information. Marsha received her academic training in epidemiology and public health at the University of Miami School of Medicine, where she spent time working in and around the Jackson Health System, a premier organization for the best in public health training. Go Jackson, go UM. Throughout her extensive academic training and professional experience, Marsha's passion remains always to harness, sustain collaborative relationships, and utilize communal expertise to solve the problems that affect individuals and communities. Marsha is an integral member of the Jamaica Diaspora Health Task Force and serves on the Public Health Surveillance and Infectious Diseases Subcommittee as Vice Chair. The presentation is being live streamed on several platforms. Please write your comments and questions, and we will try to address them as much as we can, as much as time allows. Now, please help me welcome Marsha, and a warm welcome to our team, our technical team also that's in the background, Carleen and Mr. Gillen. Thank you so much. Marsha, you have the floor.
Thank you, Dr. Frey, for such a warm welcome. It sounds, actually, I'm proud. Thank you very much for making me seem so wonderful. I appreciate that. Ms. Tomlinson, Mr. Gillen, thank you for having me and allowing me this opportunity to speak to you today and to the audience this happy Sunday. So I welcome everyone who's going to be joining us. I hope everyone, as many people as possible, can join us for today's talk. So I'm going to be discussing cardiovascular disease with the emphasis being on stroke. It is going to be an overview, so a broad overview of stroke disease. And I'm going to be talking about the causes, symptoms, risk factors connected to stroke disease. This is not going to be a discussion on clinical management because that is outside the scope of my particular experience. However, I do want us to explore some of the barriers to stroke management in Jamaica and in the wider Caribbean region. All right, the content will be as follows. I'm going to discuss cardiovascular diseases, just to give a little bit of background and just give you some basic numbers. I'm then going to move more deeply into a discussion of stroke disease. Thereafter, we're going to discuss how we're doing in Jamaica in particular and in the wider Caribbean. So how are we doing in terms of our epidemiological profile for stroke management, and everything surrounding stroke care in our region. I'm going to discuss barriers to care, and I would like to pose to my fellow professional audience members what we can do to improve our profile in our area in Jamaica in particular. And then I'm just going to provide some of the resources that I used to develop this talk. All right, so let's talk about cardiovascular diseases. These are disorders of the heart and blood vessels. The most commonly occurring cardiovascular diseases are coronary heart disease. This is sometimes also called coronary artery disease, according to the lingo of what you see. The CDC normally calls it coronary artery disease. These are disorders that originate in the blood vessels that supply the heart muscles. We then have cerebrovascular disease. These are diseases or disorders that originate in the blood vessels supplying the brain. We also have peripheral arterial disease. These are disorders that originate in blood vessels that supply the arms and the legs of the body. And we also have congenital heart disease. So birth defects that affect the normal development and or functioning of the heart. Now, these are generally caused by malformation of the heart structure, which is sometimes, which is present at birth. They're not always apparent at birth. They sometimes become apparent later on in life, in childhood, and sometimes into adulthood. So these are the major cardiovascular diseases. All right, I'm just going to move on to some basic numbers around cardiovascular diseases. Unfortunately, but not unsurprisingly, they are the leading cause of death globally. So most deaths across the globe occur from one or other cardiovascular disease. We see some of the highest rates of death in, I believe, the Russian Federation, parts of Central Asia, and some parts of continental Africa. All right, so let's give you some additional numbers. Around 18 million persons die each year from a cardiovascular disease. Now, this is an estimated 32% of all deaths worldwide. That's about 1/3 of the entire global population that perish from a cardiovascular disease. These numbers come from the World Health Organization, WHO. And this is the number through, I believe it's 2022. The majority of these, so over 75%, occur in low and middle income countries. Now, for the sake of this discussion, we will see the terms low and middle income again. So I'll just define very quickly what a low or what low and middle income economies are. According to the World Bank, let me just check my numbers. A low income country is one wherein the gross national income per person, so that's the GNI for that economy, per person in a specified year is about $1,045 US. So that is considered a low income economy. Then you have low middle, so that's about 1,046 through about $4,095 US. We then have the upper middle income economies, which are between 4,096 and about 12,600 US. So a GNI, gross national income per person, within a specified year of around 4,100 to around 12,600 US. And then we have the countries that are considered high income, which are anything above 12,700 US. So example, the US is a high income country, Canada, Australia, some European nations. For the sake of this discussion, Jamaica is considered an upper middle income economy, meaning income between 4,100 and 12,600 US per year. And those are 2021 statistics or numbers from the World Bank. Okay, so let's get back to our discussion of CVDs. So 85% of all CVDs, so cardiovascular disease deaths, are due to heart attack and strokes. All right, so let's now turn to our discussion of the numbers. This depicts incident rates for stroke around the globe, and this is per 100,000. According to the Global Burden of Disease Study, most stroke deaths, I have deaths here, although this is an incident rate, occur in low and middle income countries. We just described what those were in terms of dollar figure, but most of stroke deaths occur in low and middle income countries. We see here from this graph that the Russian Federation, again, seems to have the highest rates, incident rates. So that's new stroke diagnosis. So the highest incident rates appear to be in the Russian Federation. In Central Asia area, we have also high rates in the Middle East and in most of continental Africa. When we look at the Caribbean and Central American region, we see that incident rates are highest in the western section of the Caribbean and Central American region. So the islands of Cuba, Jamaica, Hispaniola, which includes Haiti, and the Dominican Republic have what I would consider moderate to about high. So Jamaica, for example, is in yellow. We have an incident rate per 100,000 persons of around 70 persons within 100,000 people. And we'll see later that mirrors, unfortunately, the death rate from stroke as well. These figures are from 2019. All right, I'm going to now discuss stroke disease, and we're going to just view a short clip from the CDC that just gives an overview of stroke.
Normally, blood vessels called arteries carry blood to the brain. The brain needs a constant flow of blood to get the oxygen and nutrients it needs to work properly. During a stroke, also known as a brain attack, blood flow to part of the brain has stopped. The most common type of stroke is called ischemic stroke. It can happen in an artery where a fatty substance called plaque has made the artery narrow. In one type of ischemic stroke, called a thrombotic stroke, the plaque can break apart and form a blood clot that blocks the flow of blood to the brain. In another type of ischemic stroke, called an embolic stroke, a blood clot forms in another area of the body and travels through the bloodstream. If it reaches an artery near or in the brain, it can block the flow of blood. When an artery to part of the brain is blocked during a stroke, oxygen and nutrients in the blood can't get to those brain cells. The cells start to die within minutes. A less common type of stroke is called a hemorrhagic stroke. It occurs when a weakened blood vessel breaks open and leaks blood into the brain. This blocks blood flow to the brain, and the leaking blood puts pressure on the brain tissue, which damages it. In a transient ischemic attack, or TIA, a clot blocks the flow of blood to the brain. But it's different from the other types of stroke because the clot breaks up after a short time. Transient ischemic attacks usually don't cause any permanent damage. Normally, blood vessels...
Excuse me for that. All right, so we have seen that overview. So what is a stroke? It is a medical emergency that occurs when blood flow to the brain is blocked or when it's retarded. So there's less blood flow or it's completely blocked. It then, lack of blood flow starves the brain of vital oxygen and nutrients. Following that, within minutes, brain cells begin to die. Without immediate help, there is possibility of permanent injury or death. Now, for illustrative purposes, I've presented here a very simplified process diagram for what a stroke is. And this is actually an ischemic stroke, but stroke obviously is a very complicated disease, and there are lots of overlapping and intervening processes that occur. But for the sake of what we're doing here, it's important to note that there is a limited brain flow of blood to the brain or none whatsoever. The brain is starved of oxygen and nutrients, cells begin to die, and injury or death can occur very quickly thereafter. All right, let's talk about the types of stroke. There are three main types of stroke. There is an ischemic stroke, which we described earlier, and you saw in the video. There is a hemorrhagic stroke, which you also saw earlier, and a transient ischemic TIA, sometimes called a mini stroke. Let's discuss ischemic stroke first. All right, an ischemic stroke occurs when a plaque or a blood clot blocks the flow of blood to a vessel that supplies the brain. So there is a blockage that happens, the brain does not get blood, oxygen, nutrients. These account for 87% of all strokes. So ischemic strokes are the majority of strokes that we see. They are further divided into two subtypes. So we have a thrombotic stroke, which is an ischemic stroke, but it's just another type of ischemic stroke. And we have the embolic stroke. Let's look at these separately. So let's look at this. So this is a thrombotic stroke, which, as we mentioned earlier, is one type of ischemic stroke, one subtype. In this, we see a buildup of plaque in arteries, which can lead to atherosclerosis. Typically, this happens throughout or over the aging process, but also is moderated or modulated by possibly too much of too high cholesterol over time. Plaques can harden and they constrict in the arteries, so it limits the flow of blood to the brain. Where you have an artery that is partly or fully blocked, blood does not get to the brain cells very easily. And so what happens is the oxygen, doesn't get to the cells. The cells begin to die. And then that can lead to what we call a thrombotic stroke. So there again, there is a depletion or there is a blockage of blood flow to the areas that are needed. These thrombotic strokes, these are more prevalent in older persons, and particularly those with high cholesterol and atherosclerosis. Independently, persons with diabetes have a higher risk of having a thrombotic stroke. The next type of ischemic stroke, the next subtype, is an embolic stroke. So in these, a blood clot or debris forms. This debris can be a broken plaque or something else. So debris or blood clot forms in another area of the body. So in another part of the body, usually in the heart or a large blood vessel. These blood clots travel from one part of the body and they lodge in narrower brain arteries, blocking blood flow to the brain. Again, this blocked flow to the brain starves it of vital oxygen and nutrients and can lead to what we call an embolic stroke. Embolic strokes can occur in persons with heart disease and who have had heart surgeries. About 15% of these strokes, the embolic stroke, occurs in individuals with atrial fibrillation. So AFib, as it's commonly called, is quite a major risk factor for an embolic type of stroke. All right, so the next major type of stroke that we will discuss is a hemorrhagic stroke. Before I go on, I just need to reiterate that an ischemic stroke is one where there is a depletion or a complete block in blood flow to the brain. And so the brain is starved of oxygen and nutrients. So the operative or the important process there is blood flow not getting to the brain. So in a hemorrhagic stroke, a blood vessel ruptures and causes a bleed within the brain. These account for a lot less than the ischemic stroke, which were about 87%, but these are at about 13% of stroke cases. So quite a lot less than ischemic stroke, but also fairly high at 13%. These are also divided or subdivided into two types. So we have an intracerebral hemorrhage and we have a subarachnoid hemorrhage. We'll discuss the intracerebral hemorrhage first. All right. An intracerebral hemorrhage occurs when a vessel ruptures and bleeds within the brain. These are usually caused by high blood pressure. Bleeding occurs suddenly and rapidly. There are usually no warning signs for an intracerebral hemorrhage. And severe bleeding often leads to coma or death. The other type of hemorrhagic stroke is a subarachnoid hemorrhage. These occur when a blood vessel on the brain surface ruptures. So in the intracerebral hemorrhage, we saw that these blood vessels were deeper within the brain. However, in the subarachnoid hemorrhage, it's a surface blood vessel that ruptures. Bleeding occurs between the brain and the skull, so what is called the subarachnoid space. These are often caused by aneurysms or arteriovenous malformations. Now, sometimes aneurysms are called a type of stroke. They are not. Aneurysms are what we call a ballooning of an artery. So there's a weakness in the wall of the artery. It balloons and it then bleeds and ruptures into the brain. It can cause a subarachnoid hemorrhage, but itself is not a stroke. Also, subarachnoid hemorrhage can be caused by these arteriovenous malformations. So where you have a tangle of veins and arteries that are, it's a congenital issue normally. It also can lead to a hemorrhagic stroke, a subarachnoid hemorrhagic stroke. And finally, one of the last major type of stroke that we will discuss is a transient ischemic attack. These occur when a blockage in a vessel prevents the flow of blood to the brain. They are similar to an ischemic attack, except that the blockage is transient, so it generally clears up. There is usually no permanent damage to the brain from a transient ischemic attack. However, they are sometimes followed by a full stroke, which is why they're sometimes called a mini stroke, and they're also known or considered an impending or a warning sign for what could be a full stroke. All right, a stroke obviously is a very serious medical emergency, so it is really important to understand and recognize the symptoms of a stroke. They often develop very quickly. However, there are times when they may develop over hours or even days, such as when someone has had a transient ischemic attack that turns into a stroke. The symptomology of the stroke really depends on the type of stroke and the affected brain area. There are many common symptoms and well-known symptoms of a stroke, but it is really important that we reiterate them and understand them, because a stroke, as we discussed earlier, is a serious medical emergency. These are sudden numbness or weakness, especially on one side of the body. A sudden confusion, person appears to suddenly not understand what is happening. Sudden trouble speaking or understanding speech or understanding language. Sudden trouble seeing in one or both eyes. Sudden trouble walking, so the person seems to be uncoordinated. They develop sudden dizziness, loss of balance, apparent balance, or coordination. And sometimes a sudden severe headache with no known cause. Obviously, it is important to be aware of these signs. Rapid awareness of stroke symptoms and timely attention is critical to reducing the risk of injury. Most of us are familiar with the Be Fast educational campaign. Balance. Check the person's balance. Is the person appearing dizzy, uncoordinated eyes? Do they seem to have lost vision in one or both eyes? Do they complain about having lost that? Face. Is there a droop, especially on one side of the face? Does the face appear uneven? arms. Is there an apparent weakness in the arms? Can they outstretch both arms without one falling, or both? Speech, are they having trouble speaking? Are they having trouble understanding language or speech? If any or all of these are apparent, it's obviously time to call the emergency services and attend to that person as quickly as possible. Now I'm going to discuss briefly some risk factors for stroke. There are numerous risk factors, and many of these risk factors are the same for other cardiovascular diseases. Some of these risk factors are within a person's control, so we can modify them through either medical intervention or behavioral intervention, and others are outside of a person's control. They're not really modifiable. Let's look at some of these. Stroke risk factors that are modifiable: high blood pressure, high cholesterol, smoking, diabetes or diet, physical or level of physical activity. So these are the risk factors through either medical intervention or behavioral intervention, or a combination thereof, that we can modify. We can lower our risk for stroke by modifying some of these risk factors. There are, of course, non-modifiable risk factors. They're outside of our control, or age, or gender, or race, or family history of other non-communicable diseases, and or history of having had a prior TIA or a stroke. These are not modifiable risk factors for stroke. Unfortunately, we can't do anything about our age, gender, race, family history, or the fact that we have had a prior stroke. Now we can try to prevent a prior TIA or stroke, but we can, once it's there, we can change the fact that that has occurred, and that is a risk factor for additional strokes. For the risk factors that are controllable, there are some simple and standard recommendations. The World Health Organization, the Centers for Disease Control and Prevention, and other bodies, other medical and bodies have come up with a number. Some of these are, obviously we saw earlier, high blood pressure. Make control of high blood pressure your goal. Control your blood pressure, either through medication, exercise, diet, combination of all those. High cholesterol, work with your doctor on a treatment plan to manage cholesterol. Diabetes, work with your doctor on a treatment plan to manage diabetes. Tobacco use, now if you don't smoke, do not start. If you do smoke, reduce your intake of cigarette, and preferably try to get help to quit, to cease smoking cigarettes altogether. Unhealthy diet, obviously, eat a healthier or try to improve your diet. Lower your sodium intake, lower your salt intake, trans fat. Improve your intake of fresh fruits and vegetable. Physical inactivity, increase your level of physical inactivity if you believe it's not enough. Now, according to the Surgeon General, it is recommended that an adult engage in moderate intensity exercise for 2 hours and about 2 hours and a half minutes every week. If you're below that, try and improve that figure. And obviously, weight management is very important. So work to have a healthy weight for your height. All right, let's now turn to how we are doing in Jamaica in terms of the numbers. The information here comes from the World Health Organization and the World Stroke Association. The numbers are current through June 2022. At this point, we are, after adjusting for age, my apologies, after adjusting for age, stroke is the #1 cause of death in Jamaica. So this is age standardized death rate for our population. And after adjusting for age, we see that stroke is the #1 cause of death in Jamaica. Our rate is 70 stroke deaths per 100,000 persons on the island. Our ranking in the world is moderate. So we're not in the poor category, but we're not in the good category either. We're in the moderate category. So of, I believe, 169 countries measured in this, we are at a rank of 104. So we're in the moderate category in terms of where we are in terms of our stroke death rate. Now, let me digress a tiny bit. This is a stroke discussion, but I have to point out that our prostate cancer rate is we rank 3 in the world. So out of 169 countries, our prostate cancer is 3. We need to have a discussion about that, but let's get back now to stroke. When you look at all the numbers, so in absolute numbers, stroke is still the #1 cause of death in Jamaica, and it accounts for about 14% of all deaths. When you consider every age group and all other diseases, it is still #1, and where it's about 14% of all deaths on the island is caused by a stroke. So we had an epidemiological profile of what's happening in Jamaica, and we've seen some of the numbers, incident rates for the Caribbean. What are some of the barriers to stroke care within our region, within our island, and within our region at large? I had done what I thought was an extensive literature review to get some information on what's happening in our area. Unfortunately, there isn't a great deal that focuses on Jamaica in particular, or the Caribbean region. But what I have found suggests that there are systems and individual barriers to improving stroke care and to improving our numbers in our region and in Jamaica in particular. The systems barrier, so the barriers at the system, the level of the health department and beyond. Inadequate access to hospital facilities. We have we don't have enough hospital facilities. There are limited numbers of rehabilitation facilities once a person suffers a stroke. There is inadequate or no access to follow-up care for many persons. And there are few surveillance activities for stroke and stroke management. At the individual level, at the caregiver level, these are some of the barriers. Caregivers often have low education levels. Now, this is the lingo, or this is the language that is actually used in a lot of these research studies. I would prefer to say that many of the caregivers just do not have the experience of managing someone who has suffered a stroke. I'm not sure the level of education is critical, however, experience is. So caregivers don't have the experience. The research literature uses low levels of education, so I put it here in that way. Individual caregivers generally have low or limited resources, so they don't have enough of what they need, either financial resources or other resources, to manage care for themselves or for the caregiver to manage the person who has suffered a stroke. And at the individual level, again, there is an inability to provide or to access rehabilitative care for the person who has suffered a stroke. So how do we manage these challenges in Jamaica? How do we manage these challenges in the Caribbean? These are the World Health Organization targets for managing non-communicable disease and including stroke. Now, this is a document or targets from 2013 to 2020. I have not seen anything more recent. They have 9 targets. I'm going to focus on the last 4 because I believe they are more directly relevant to stroke management and strategies for improving the profile of stroke care in the Caribbean and in Jamaica. So these are the World Health Organization and other bodies would like for there to be a 25% relative reduction in the prevalence of raised blood pressure, which is a very good thing, or to contain the prevalence of raised blood pressure according to national circumstances. The next is to halt the rise in diabetes and in obesity. At least 50% of eligible persons receive drug therapy and counseling, including glycemic control, to prevent heart attacks and stroke. And the last one is an 80% availability of the affordable basic technologies and essential medicines including generics, required to treat major non-communicable diseases in both public and private facilities. These things tend to be a bit wordy, but let's focus on the last two. So 50% of eligible persons in Jamaica, for example, or the Caribbean, receive drug therapy and counseling to prevent heart attacks and stroke. And 80% availability of the affordable basic technologies to prevent non-communicable diseases in both the public and the private facilities. My question that I would pose to audience and my colleagues is, how practical are these targets within our region, within Jamaica, within the Caribbean, and beyond that as well, especially the last two? 80% availability of basic technology to everyone, private and public facilities. Okay, so let's talk about some strategies for improvement. We can employ some of the best practices that work for all NCDs, for all non-communicable diseases and for cardiovascular diseases specifically, and stroke. We can improve awareness. So stroke and cardiac health awareness education, we can provide or improve this. We could create and strengthen stroke surveillance activities. We could create and or strengthen home assessment for survivors of a stroke. We could create and or strengthen mobile rehab services. We could work on eliminating the stigma around stroke, and we could eliminate the notion of stroke as an inevitable, my apologies for the typo here, inevitable consequence of aging. Now I'm going to pose to the audience and or colleagues, are there other strategies that we believe would work for our country, for our area? What are other ideas that we could come up with? The World Health Organization has asked us to put on a big show, 50%, 80% availability of technologies in public and private facilities. Can we do that within our region? These are some of the resources that I've used for this: the National Institute of Health, obviously American Heart Association, American Stroke Association, Hopkins, Centers for Disease Control. The World Health Organization obviously is a plethora of great information, Pan American Health Organization, Jamaica Stroke Alliance. I just want to mention here that the Jamaica Stroke Alliance was inaugurated in 2020, and it is, from what I've seen thus far, one of the only ones in our country that is doing surveillance at the national level and working with partner agencies to develop a surveillance system and a system of improving healthcare and management of care around stroke. Obviously, the World Bank information is always important, and the World Stroke Organization is extremely important. Additional resources is Hearts in America. Hearts in America is a program where now 22 countries that have collaborated with PAHO, which is a subsidiary of the World Health Organization. I'm not sure why Jamaica is not a part of that yet, but we should look into well, I don't know if we are going to be a part of it, if we're working to be a part of it, but it would be nice to see our island as part of this Hearts in the Americas program. So I've used some of the information from their technical package and obviously the United Nations Sustainable Development Goals as well, and Global Action for Prevention and Control of Non-Communicable Diseases, which is what we had seen from the targets. And that is the end. I will take any questions or discussions as arise.
Thank you so much, Marsha.
Thank you.
That was a very informative presentation related to stroke. And we have a comment here from Dr. Thompson. He said, thanks for presenting and exploring the barriers on this important health issue, Marsha. Carlene, are there any questions from YouTube?
So far, we haven't had any additional so far.
I just like to, thank you, Carlene. I just like to stress some of the points that Marsha made, especially about the factors, the ones that we can modify, such as diet, exercise, to decrease our risk for stroke. Marsha, could you just go over those modifiable risk factors and also the signs and symptoms of a stroke? Because many times people are having stroke and they don't even realize that they're having it. So I think those simple, they seem simple, but they can save our lives. So could you just review those again for our audience?
All right, which one would you like for me to do first? I can do the modifiable risk factors, or I can do the symptoms. Let's do the symptoms first, as it appears first in the
you can do the be fast, whichever one comes first in the presentation. I think you can go over that. Thank you.
Okay, my pleasure. All right, so these are the symptoms again for a stroke. We have sudden numbness or weakness, especially on one side of the body. We have sudden confusion or trouble speaking or understanding speech, understanding languages or language as is normally spoken to us. We have sudden trouble seeing in one or both eyes, sudden trouble walking. We have developed dizziness, loss of balance and or coordination, and sometimes a very severe headache with no known cause. So these are some of what we call the classic symptoms. The be fast. Now, obviously, the rapid awareness of these symptoms is critical to preventing permanent injury or death from a stroke. Balance is a person seeming to be uncoordinated. They're not balanced. They can't walk in a straight line. They've developed a sudden lack of coordination. Eyes. Do they seem to have lost vision? Do they say that they've lost vision in one or both eyes? The face. Is there a noticeable unevenness about the face? Is there a droop? Does it appear that there is a droop to one side or other of the face? The arm, can they stretch out their arm without one appearing to be weak? So do they seem to have weakness in one of the arms or both? Do they have difficulty speaking? Do they have difficulty understanding speech? And if any or all of these are apparent, obviously we want to be able to get them to the emergency services as soon as possible. So those are the signs that we should look for, and that's the response that we would like. Immediate. Call the services, call the emergency services, and get that person to whatever help they can get as fast as possible. As far as the modifiable risk factors for stroke, obviously, if you have high blood pressure, it's something that should be managed, obviously, with a primary care physician, if that is available to you at clinic, but manage your blood pressure. High cholesterol, manage your high cholesterol. Make sure that you use whatever is at your disposal, medical care, clinic care, medical intervention, diet to manage that high cholesterol. Smoking, do not smoke, do not start if you do not smoke. If you do smoke, get help to stop, cease smoking. Diabetes, obviously you want to manage your diabetes and the symptoms of your diabetes with your physician. Your diet, if it's not healthy, if you believe it's not healthy, if it's high in sodium, high in salt, try to reduce your intake of salt. Try to eliminate it if you need to. Obviously, eat have a diet which is higher in fruit and vegetable and lower in trans fat, especially trans fat. But we also want to lower our intake of salt, sodium. Physical activity, we always want to improve our physical activity. We want to maintain a healthy weight. The goal isn't to be thin, it is to be healthy, to have a healthy weight for our size, for our height. And so those are the risk factors that are modifiable. They may help us reduce our risk. Nothing can completely eliminate a risk, but you can reduce your risk factors for a stroke or any other cardiovascular disease by taking on some of these. The non-modifiable risk factors, there's nothing we can do about our age. Obviously, we were born one or another gender, so there's nothing that we can do about that or what we were born. And obviously the phenotypic manifestations thereof, or race, family history of non-communicable diseases, and whether or not we have had a prior stroke. Once we've had a stroke or a TIA, we can't go back and undo those. So these are non-modifiable risk factors. As I said earlier, we could try to reduce our risk of getting a TIA to begin with, or a stroke, but we cannot, once it happens, we cannot modify, we can't change the fact that that happens. And having had a TIA or a stroke is sometimes a risk factor for having another. I'm just going to go again over the World Health Organization and CDC recommendations for high blood pressure. May control your goal. Now, they don't say how, but obviously through your medical intervention or diet or exercise for high blood pressure. Cholesterol, work with your doctor on a treatment plan to manage your cholesterol. Diabetes, obviously you want to work with your doctor on a treatment plan to manage the diabetes. Smoking, don't smoke. If you do, get help to quit. Unhealthy diet, again, lower your salt intake, trans fat. Higher, make sure you eat more fresh fruits and vegetables if they are available to you. Physical inactivity, if you're getting less than 2.5 hours of exercise, moderate exercise a week, try to improve on that. And weight, manage your weight. Try to maintain a healthy weight for your height. And so those are the controllable risk factors. Those are modifiable risk factors. The others, we are not in control of, unfortunately.
Thank you, Marsha. Yes, so we do have some control over
We do.
whether or not we get a stroke. And Marsha mentioned high blood pressure, management of high blood pressure. There are some medications that we take for high blood pressure that can, inhibit our function in some areas, and especially among men. Many of our men do not take their high blood pressure medications because they interfere with, with virility. Now, nowadays, we have medications that are targeted. Please report these interferences to your doctors. Talk to your doctor about the fact that the medication is interfering with your sexual performance. They can change it. There are many choices. Medications can be targeted for you specifically nowadays. So because we have the technology, please talk with your doctors, have a conversation, because as you can see, high blood pressure is one of the biggest risk factors for a stroke. And many people are walking around not knowing that they are suffering from high blood pressure. Cholesterol, that's another big deal. Make sure, because there are fats and fats and fats. Many times we say, okay, olive oil is the best, but if you look at the cholesterol content, or not the polyunsaturated and monounsaturated content of olive oil, sometimes it's not the best. So we need to make sure that we're checking to see what is in our food, what is it that we're eating, what is it that we're consuming that can place us at risk. Physical activity, again, in all spheres of life, physical activity really works to protect us against many diseases. Thank you, Marsha. I think we have some more questions, so I'll go to that. Can we have, let me see, based on the barriers and targets, what can the diaspora do to assist Jamaica?
I thought about this for a long time, and when I was devising this presentation, I kept going back to the one that about barriers to care, barriers in our island. Let me try to get back to that if I can. Let's see, here we are. The barriers that we have. And these are the barriers that is identified in the scientific literature on stroke. And this is for low income and middle income countries. Remember that Jamaica is now considered an upper middle income economy. Still, we are a middle income economy nonetheless. And so we have the systems barrier. We have hospital facilities, inadequate access. We have limited rehab facilities in places where people are, have easy access. We have very limited access to follow-up care. We have few surveillance activities. And at the caregiver level, we have people who are not as experienced or people who are not experienced in managing someone who has suffered a stroke. We have limited resources in terms of how much money they have to take care of someone who has had a stroke, or how much money does one have who has had a stroke and is trying to take care of him or herself. And sometimes we have an inability to be able to access these rehabilitative care. And then when you intersperse that on some of the targets that the World Health Organization or other bodies have suggested, 80% of availability of basic technologies and medicine in public and private facilities. My question would be, how practical is that in the context of a middle income economy? How practical are these? What can we do? That is a good question. I cannot answer that. I can only say that I do hope that we can work together as a diaspora to build the capacities on our island. I mean, if we have people, one of the things that people complain about is that they just don't have rehab facilities. I'll just interject a little bit of personal information here. My father passed away from stroke in 2021 in the middle of the pandemic. I believe he had what seemed to have been a TIA. He lives in Portland, my favorite parish. We live, my grandmother, his mother, his beloved mother, my beloved grandmother. We live in the area called Rose Hill Gap. It is absolutely stunningly beautiful. It is at the foot of the Blue Mountains. He had a TIA, so it means that he had to get down to the closest hospital was Anato Bay Hospital, I believe. He was sent home a day later with what they said was a negative MRI. Within 3 weeks, he had passed away. Within a week of that, we had him down to St. Margaret's Bay in a rehabilitation facility because we thought he had had a minor stroke based on the information from the Anato Bay Hospital. And it turns out when he got to the rehabilitation facility, they said that his care was too much for a rehab facility. So he was sent to Port Antonio Hospital, where he passed away within 3 weeks. Now, my father, like Dr. Frey had mentioned, was a man who was concerned about his virility in the sense that he did not want any medication that would make him what he considered less of a man. But he was someone who was very much concerned about his blood pressure. He tried to eat well. He was exercising. He was in otherwise great health. What were the sets of circumstances that then precipitated his, what I would consider untimely death? Is it lack of follow-up care? Is it lack of experience of his caregivers? Is it the fact that there was a pandemic at the time, the hospital had to discharge him? Is it the fact that there was no assessment thereafter? What sets of systems are there for persons like that? And there are lots of people in Jamaica living in the same types of circumstances. They live in rural areas of the island. They may have had a stroke or even a TIA. They may have no follow-up. They may have no care thereafter. They may not have access to a hospital facility in a timely manner. And these are the things that, as an island with a lot of rural parts to it, with a lot of people living in rural parts, that we have to deal with. So inability to provide or to get access to rehabilitative care, inadequate access to hospital facilities. Are these some of the things that we can work on as a group, as a diaspora, to improve stroke care? I mean, and the other, another thing that I thought about was many people in our island and beyond see stroke as almost an inevitable part of growing old. Many people I know in Jamaica have had a stroke. My own grandmother's had a stroke. She had a TIA. I know many people have had a stroke. It's almost an adult rite of passage, the way we think about it. It's almost inevitable. We need to remove that from our culture, our national culture, that stroke is, well, you know, the person was kind of old, he was old or she was old, not taking care of herself or himself, too much salt, had a stroke. And we need to also remove the stigma, oh, had a stroke, as if it's a death sentence. It is another, it's a serious medical condition which can lead to death and permanent injury, but we need to treat it as something that is manageable, either through modifying our risk factors for it or providing the care that is necessary once someone does suffer a stroke. How can we manage our hospital facilities? That's a large task, but we can do other things, perhaps better follow-up care for persons who have had stroke, better surveillance activities, maybe in-home care. That might be a tall order, but these are some of the things that I think the diaspora as a group with experience, expertise, passion can start to work on.
Thank you, Marsha.
Thank you.
In addition to what you said, I think education, more than anything else, is going to be one of the major ways of treating, you know, helping our caregivers to treat patients who suffer from stroke in Jamaica. So someone asked, can we have designed basic training for caregivers in Jamaica? Yes, that's exactly what I'm talking about. We need to, you know, leverage the expertise that we have here and see how we can partner with our fellow Jamaicans to educate caregivers at home. So, you know, education is definitely a part of it. And that's why we're doing this Jaminar today. That's one reason for this. More comments. Medication compliance for blood pressure seems to be hard to achieve, especially among males. Do you have any recommendations? And I think we've talked about that earlier. We're kind of running out of time, but yes, it's just a matter of communicating what's happening, because many men, when they are not performing in that area, they don't want to talk about it. You know, they hide it and they just stop taking the medication. But I think a big part of it is communication and trust. They have to trust their doctors so that they can talk to them. Trust your significant others also, and let them know what's going on so that they can point you in the right direction.
I think also medication compliance comes down to a matter of, can they afford the medication? Is it available for free, or is it available at reduced cost? I do know of people.
That's a great point, yes.
Who they're cutting the medication because they're trying to, what we call, stretch it. These are not,
yes.
This is something that we have to work on. There are people that just don't have access to that clinic or wherever they have to go every 6 months. They just, they can't do it. And so what they'll do is cut the medication and stretch it. And they'll eat a little bit of callaloo because they were told that it's good for their blood pressure. So they'll mix and match what they can do. We have to move beyond that. I understand that these folk remedies are, you know, good. They're not terrible. Callaloo is a good thing to eat. However, it isn't enough to help you with your blood pressure when you do have
other things going on.
Yes, have underlying, right, and comorbid
comorbid conditions. Yes. Plus, some people, instead of going to the doctor, they take their neighbor's medication or their friend's medication.
That happens as well.
May not be for them.
It's not
appropriate
for them, of course.
Yes. Comments. Marsha, thanks for a very on-point presentation. That came from Joan. Thank you, Joan.
It's a pleasure, Joan.
Sandria, public education on prevention strategies. The practitioners, especially in the public spaces, are grossly limited in time for patient teaching. You are so right.
Absolutely.
Yes. Another comment. Thanks for your response to my question, re-diaspora contribution, Marsha. This issue can be explored further during the upcoming health summit. Yes, that's from Dr. Thompson. Definitely. More comments. We need stroke management centers. Yes, definitely.
We do.
Can you just mention the summit?
Yes. Thank you, Carlene. Let's mention the summit will be held in Toronto, Canada, It's a health summit being sponsored by JDTAN and especially the JDHTF, which is the Jamaica Diaspora Health Task Force. And it's going to be held at George Brown College in Toronto, Canada on between August 29th to 31st. So please plan to be there. It's going to be life-changing, and it's targeted to the diaspora, of course, and particularly Jamaicans. So please come, please support us. We hope to have experts in different areas. We will also have tours to state-of-the-art facilities where permissible. Because of COVID, we have to be careful, but this is going to be in person. And George Brown College is a waterfront edifice right there in downtown Toronto. So, you know, it's well located. Please, again, plan to attend. Thank you. Thanks, Carlene, for reminding me about that. We need stroke management centers in Jamaica. Everything goes to the General Emergency Department. Stroke specialists are needed. Yes,
Absolutely.
definitely. I think it's 4:01. Is our time up, Carlene?
We are at the border. We really are. This has been wonderful.
We have some more comments coming in. I think we're going to take the last comment and then we're going to go. Dorothy Brown says, great informative presentation. Thank you all. Thank you, Marsha. Thank you, Carlene. This was amazing. This was, we really should have done this last month because, you know, we're trying to follow the calendar of WHO, but it's never too late for a discussion or information on stroke because it is such a common phenomenon and so many people are walking around and they're time bombs for stroke. Again, guys, please talk to your doctors, listen to your body, watch out for those signs and symptoms, be fast, all right? You may have some drooping, some weakness, don't ignore them. Your body is speaking to you. Absolutely. And our body, you know, just listen to your body and follow up. So thank you all for joining in, and we will see you at the next Jaminar, which will be on the 29th of June. And that one is related to mental health. Thank you again. Have a great afternoon.
Thank you. Bye-bye.